All right, so the next topic will focus on contrast administration for computed tomography, and it really will go into some of the basics and some of the principles. Now, if you think about CT angiography, which is, I think, a good proxy for all of these contrast injection protocols, is what you really want to do in a CT angio is you want to acquire CT data at a higher resolution. You want to have strong material enhancement, and you usually need some post-processing, and usually you can ultimately scan head to toe and have some CT angiographic protocols for almost anything. The tricky part is that while you scan, you need to synchronize your acquisition with the time of maximum arterial enhancement. And how you link those two together is not always intuitive, and there are some intuitive elements to it, although as I'll hope that I can show you that some very simple rules work very well. And the good news is that these rules haven't changed in the last 20 years, and they will not change in the next 2 million years either. So what I'm trying to achieve in this next half an hour or so is I want to really try to explain what the early contrast dynamics mean. What is the relationship between intravenously injected contrast and arterial enhancement, and for that matter, the downstream parenchymal enhancement? So I want to teach you 4 very basic rules that can be used to understand how vascular and organ enhancement work, and then show you some examples how these principles can be applied to build scanning and injection protocols, because that's in fact what all our protocols here are ultimately based on. So let's start first with the key rules to understand the relationship between IV contrast delivery and arterial enhancement. So essentially we are talking about a time attenuation response and derive those rules. So if you think about it in a more say theoretical aspect, you can say pharmacokinetically that all the radiographic contrast media that we use in CT, the gadolinium behaves very similar. They're extracellular fluid markers, and they are distributed typically in the intravascular space, which means usually in the vessels, and then they're also in the interstitial space. So once they're in the liver and they get into the interstitial space, then the whole organ enhances, and ultimately they're going to be excreted by the kidneys. So early contrast dynamics refers to the kind of complex phase while contrast is still coming in. It gets distributed and redistributed between all these spaces before it gets ultimately excreted. And so that's the thing that we want to look at. Now, you can in fact calculate this very specifically, at least in a theoretical model. You can calculate exactly how much iodine molecules you inject into the arm vein, and then trace it with all these kind of functions here, where it gets into the different organs and vessels, etc. And you can calculate the time enhancement, so the enhancement over time in every vessel and organ just by knowing what the attenuation will be in at different points in time in different organs. But it's much easier to think about it in this way. So if you inject contrast medium into an arm vein, like in this example, then we know that the contrast will first end up from the venous system in the right heart. Then from there it will go obviously to the lung, the left heart, then into the arterial system. So for CT angio, we are mainly interested in what happens between contrast injection and the arterial system. But obviously the contrast will not stay there. It will go into all the other organs, for example, into the spleen, intestines, and from there into the liver. And then ultimately the contrast will come back to the venous system and then recircle, and so it will kind of recirculate. So the contrast that you inject and you see on the arterial side will ultimately come back until it's distributed everywhere and then excreted by the kidney. Now, what's a good way to think about how contrast that you inject affects your arterial enhancement? And there's a very simple cartoon that illustrates that. So if you think about, it's here on the left-hand side, this symbolizes an injection protocol. You have a 4 cc's per second, 60 milliliter of bolus. You see this is kind of symbolized here. So this would be time. And then also over time, you can measure the attenuation values, let's say in the abdominal aorta. So if you give a very small injection, 16 cc's over 4 seconds, what you'll see in the arterial side is you will see an enhancement response. So you will see at some point in time the contrast will appear in the artery. So the time interval between the start of the injection and when the contrast appears here in the artery is usually called the contrast medium transit time, which is usually used to help with a delay. But then what's also important is when you look at the remainder of this curve, that the contrast or the opacification does not return to zero. Okay, so it undulates a little bit above zero. And the reason is because once the contrast bolus is in and it washes through the arteries, there's a lot of contrast that comes very, very late, and this is what makes this tail. And it's important not to ignore this for our modeling. Now, the first question that you are probably wondering is, well, what happens, and also just for terminology, that this first pass of the curve we usually refer to as the first pass of contrast, and the remainder is actually called recirculation, despite, as I mentioned, it's also part is bolus broadening. It's not only recirculation, but the fact is that it does not return to zero. Now here's a quiz for you. Let's imagine that you have, instead of a 16 milliliter test bolus at the injection rate of 4 cc's per second, now you inject just twice as much, and you inject it twice the flow rate, assuming that the nurses allow you to do this at this flow rate. But what's going to happen in your arterial system is that the curve that you see in the aorta will look exactly the same, except that it's just twice as high. And the reason is that it's directly proportionate to how much iodine you inject. So if you inject twice as much or twice as fast, your peak will be twice as high, and your initial incline of the enhancement curve will also be twice as fast. So this is very intuitive, and this is already the first rule for contrast enhancement. It just means that arterial enhancement is directly proportionate to the iodine administration rate. So injecting 25% faster will give you 25% more enhancement. Using contrast that is half the concentration will give you half the enhancement, because the iodine delivery is accordingly lower. Now, the second part that is way more unintuitive is that, but important to understand arterial enhancement is what happens if you're not doubling your injection rate and your volume, but if you double your injection duration. So let's say you double your volume to 32 again, but now you just inject for 8 seconds rather than 4 seconds. So the question is, what do you think? How is this curve going to look like? Is it again going to be twice as high as before? Or is it going to be twice as wide? Or what's it going to look like? And the way how you can think about it is that you could regard each of those test boluses, as you can see here, as it's having its own response function. So if you have one test bolus, this will be the time attenuation response in the aorta. If you double your test bolus, then you can think about it like a second test bolus, injected immediately after the first one, and you'll get a second enhancement response, which is offset exactly 4 seconds from the first one. And now if you inject, let's say, 128 cc's of contrast, or 8 times the test bolus, then you'll get 8 time attenuation responses. And what's going to happen overall in your arterial system is easy to imagine, because you can just have to add all these time attenuation responses on top of each other, and then you'll get a typical arterial enhancement curve as we have always seen it with a CT angio. You have an initial fast increase, and then you still have a continuous increase over time as long as you inject before the contrast drops down. And the reason why it continues to increase and doesn't stay a plateau is because each of those new test responses adds on the prior tail end of the injection, which never returns to zero. So you get this overall cumulative enhancement. So the main message of this is that arterial enhancement does also increase if you inject longer, but it's not directly proportional. It's a little more complex. It's in a cumulative fashion, because it adds up, all the different injections add upon each other. What stays relatively constant, though, is that the overall duration where you will have good contrast still correlates very well with the injection duration. Okay, so no matter how each of these curves look like, if they are spaced 4 seconds apart, the total width of your available opacification will stay the same. So for the mathematically inclined among you, you can also explain it in just a few letters and brackets. And so essentially what this formula means, it means nothing else but that the arterial enhancement over time, so it's a time-dependent enhancement, is nothing else but the sum of, which is this sign here, the patient-specific enhancement response, and then multiplied by initial injection, by the injection duration. So essentially it means just what we just mentioned in a more complicated fashion, if you like. But the simple consequence of that, and I think that's maybe the most important slide for everyone to understand, is that we are usually inclined to think of injection protocols as volumes and flow rates, like 120 cc's at 4 cc's per second. And the reason why we usually think about it in these terms is because that's how the injector requires you to punch in the numbers, because you punch in the volume and you punch in the flow rate. But it's not intuitive for what we would expect the arterial enhancement will be, because the arterial enhancement is in fact better explained by the flow rate and the total duration. So if you have a flow rate of 4, it means you have a decent arterial enhancement. And if you inject 4 cc's for 120 cc's, it means that your injection duration will be 30 seconds. So this is really what you are looking for. You're looking for the y-axis, which is the flow rate, and the duration is the x-axis, whereas this one here is more complicated. But again, if you have 150 cc's injected at 5 cc's, this will give a very bright arterial enhancement also for 30 seconds. And if you have a 60 cc's and if injection rate of 6 cc's, it will give you very bright arterial enhancement, but the enhancement will only be available for maybe 10 seconds. So if you have a scan time for a CTA that is 15 seconds, then this protocol will not be very successful, because you only have really good enhancement for 10 seconds. So that's really the key of understanding how the enhancement works. This is a good example. So this was a patient who had 2 scans relatively soon after each other. So this was in the very old days of a single row scanner. Back in the days we said, well, if the scan time is 40 seconds, we also have to inject for 40 seconds, which we did. And if we need a flow rate of 4, well, then we have to give 180 cc's of contrast. So it sounds makes perfect sense, because as long as we inject, we'll have some decent enhancement. Now, just a few months later, the patient came back for his follow-up while the scanners got faster. This was from a single row to a 4-row scanner. Now the scan time was 16 seconds. Now, we employed the same technique, or the same idea. We thought, well, 4 cc's per second is good for arterial enhancement, but now the scanner is so much faster, more than twice as fast. Now we'll need less than half of contrast, and we expected the images to look perfectly the same. But when you compare the degree of enhancement between those 2 scans, it turns out that the newer, better scanner has less arterial enhancement. And then we thought, well, how is that possible? It really puzzled us. But it's easily explained when you think about the rule 2, where the enhancement increases cumulatively, because what we in fact did is instead of injecting a lot of these test boluses and letting the contrast increase over time, we injected much shorter, and so we reasonably cannot expect the enhancement to reach the same enhancement. So because we didn't account for the fact that the enhancement is not directly proportional to the flow rate alone, but it also accumulates over time. So once you shorten your injection duration, also your enhancement will not be as good. Now, what can you do to still make your enhancement better despite your scanner is faster? Well, there are a couple of things you can do. The first thing that is relatively simple. You could just use Rule 1. What does Rule 1 tell you? Rule 1 tells you that the arterial enhancement is directly proportional to the iodine administration rate or to the injection rate. So if you just increase your injection rate, let's say from 4 cc's to 5 cc's per second, your enhancement will also increase proportionately. So that's a very simple way to just improve your enhancement again. The other way you can improve it, you can just increase your injection duration, not as long as it was before, but just increasing the injection duration for 8 seconds will result in a little more enhancement or cumulative enhancement than if you wait another 8 seconds before you in fact start your scan. Then you will scan at the tail end of the injection and you will have a much better enhancement than before. And this is where our scan delay of 8 seconds, which means our so-called prep delay, when we wait 8 seconds after the contrast arrives in the aorta, that's when we start our CTA. This is where it comes from. We inject 8 seconds longer than the scan time, and we wait 8 seconds once the contrast arrives, which will move our acquisition to the tail end of the scan where the enhancement is best. Now, the third rule is, I think, also again very intuitive. So obviously we have to account for patient factors. It turns out that the arterial enhancement can vary by a factor of 3 between patients. So give the same amount of contrast and one person enhances 100 Hounsfield units and the other one enhances 300 Hounsfield units. The underlying physiologic mechanism is cardiac output and central blood volume, which unfortunately most patients don't know if you would ask them about it. And there's really quite some variability. So here's two patients which illustrate this very nicely. There was a 88 kilogram 51-year-old man and compared to a 67-year-old woman with only 60 kilograms. And so we calculated the scan times were like 30 seconds, 34 seconds for this scan, 22 seconds for this scan. The delays were also a little bit different. This was based on a test bolus. And when you look at the shape of the test bolus alone, back in the days we still did test boluses, you can see that the younger, heavier men enhanced very little for the same test bolus, whereas this woman enhanced much, much stronger for the same test bolus. Again, it was 16 cc's, injected it 4. And this translates into a very different total amount of contrast needed for their scan. Again, the patient function is what really is different between those two scans. So similar as you can, and once you know what the patient function is, which you can in fact extract from this time attenuation curve, you can calculate. Not only you can predict how the enhancement will look for a given patient, but you can actually reverse the problem. You can say, okay, how much do I need to inject to get an ideal, a plateau-like enhancement? So I want an enhancement of 200 above baseline. This is what you would have to inject. Obviously, you cannot inject in such a weird fashion, and you also cannot inject negatively. So you cannot suck out blood again after the end of the injection. That's usually not very useful. But you can model like a biphasic injection into this. So if you have a biphasic injection with initial high flow rate followed by low flow rate, this will usually result in a relatively homogeneous enhancement over time. And shown because again, you see the initial peaks are much higher than the continuous peaks in this particular example. So in both patients using such a mechanism, we calculated that the younger, heavier man required 160 cc's for the same degree of enhancement as this woman. She didn't even need 50 cc's of contrast to get the same enhancements. Again, it shows you it's a factor of 3 difference between those two patients. Some of it is related to weight, but some of it is also probably just cardiac output. So the basic rule means that the least thing we should do for patients when we give them contrast is we should adjust the contrast dose for body weight. This will not eliminate all the variability, but at least will reduce it. Okay, so to not adjust it really makes no sense, because most other medications you dose based on body weight. So why wouldn't you do this for contrast medium as well? Because other people have tried to use body surface area, lean muscle weight. Also, lean muscle mass is probably the most accurate, but it's more complicated to calculate. The body mass index is in fact not a good parameter to dose contrast, because what's body mass index good for? What do you prescribe based on a body mass index? Based on body mass index, you only prescribe a diet. right? Because it means that if your body mass index is very large, then you need to maybe lose weight, or the other way around. But you can be very small and short and round, and you can be very large and heavy and can be very muscular. It's not the same thing, right? So you don't prescribe your contrast based on the BMI. This is really something you would want to avoid. So I would say body weight is not perfect, but I think it's still a very accessible and reasonable thing to do. Now, there's only one more parameter we want to not ignore, is that when you think about everything we've discussed so far, that the rule 1, where injection is directly the enhancement is directly proportional to injection rate. Number 2, the enhancement is also proportionate to the cumulative, to the length of the injection. Then patient factor or patient weight is an important factor. But what we have ignored yet is the vascular territory. So if you scan not only at one slice where you do the test pulse, but you scan a whole territory, then you have to keep in mind that the territory also can be abnormal. So you can have an aneurysm, you can have a stenosis. And so here's an example that taught us this lesson. So the patient had in fact a prior body CT where an abdominal aortic aneurysm was noted, and then the patient was referred for a planning CT to do a CT angio. So we just had gotten a 64-row scanner, and we started to scan immediately once the contrast arrived, and we scanned in, I don't know, a few seconds, and we noticed that the enhancement of the aneurysm was in fact much worse than on the initial outside body scan. And the reason was because we were just too enthusiastic. We just scanned through that, and we didn't allow the contrast to mix in those aneurysm sacs, which is not good. So you don't want to scan too early and too fast, and it can take quite some while to fill these aneurysms. The same is true for dissections. You can have a false lumen that enhances later, and you can have patients with peripheral artery disease who have a lot of stenosis, but also takes a lot of time to trickle. So you do not want to necessarily scan too fast. So here we saw we triggered too early, and we didn't really achieve a good scan time, a good enhancement. So how do you kind of build protocols based on those very, very simple rules, and so that they're also easy to implement on all scanners and across all patients? So the basic rules we just mentioned, but another complication that has happened over the years is that while the scan times were in the 40 seconds range about 20 years ago, now the scan for an abdominal scan could be 4 seconds. You can scan the abdomen in 1 second. You can even scan the chest, abdomen, pelvis in less than a second if you use a force by its maximum speed. So scan speed is really not a limitation anymore. Instead of what we did in the past, where we usually did a scout, we planned the CTA, we looked how long it takes to do the CT angio, we looked how many seconds those were, and then we said, okay, for so many seconds we need to inject that long. None of this is necessary anymore. So what we can do now is, in fact, we can, rather than building our protocols based on the speed of the scanner, we can just reverse the problem. You can say, okay, how much contrast do I need to get a reasonable enhancement for a reasonable amount of time without popping every other vein by injecting too much, and getting a reliable scan, and having the ability to scan to inject faster if you have a big patient and less if you have a small patient. So we know this physiology because it's all included in our basic rules. It's injection rate, injection duration, and it's patient size. And then once we know how this would work, we say also, well, we don't inject very short because it will not give us enough enhancement. We also don't want to start the scan immediately when the contrast arrives, but we want to give it some time to fill an arterial territory of interest. So rather than building our protocols based on how fast a scanner can scan our territory, we can just set a fixed scan time. We can just tell, why don't we just scan every CT angio in 10 seconds? And this is a very simple approach, because it means if everybody has a scan time of 10 seconds, then the pitch will be variable. You use automated tube current modulation to adjust for the radiation dose. And then you can simply combine it with an 18 seconds injection protocol. Again, this is because we want to inject 8 seconds longer than we want to scan. And we want to need this because we want to give the contrast 8 seconds head start to fill the vascular territories. And then we use bolus triggering to start our scan. And once the contrast hits the arteria of interest, like the aorta, then we count down for 8 seconds, and then we scan. And that's a very simple protocol, and it would work for almost any standard territory. It also allows you to adjust for body weight or different sizes, because since the injection duration and the scan time is always the same, you can make a very simple table that says, okay, for the average person, you inject 5 cc's per second, and you need 90 cc's of contrast. If you have a smaller patient, your flow rate is less, but your volume will be less accordingly, because again, the injection scan time and injection duration are always fixed. In large patient, you can inject 6 cc's, and you will need 108 cc's of contrast. So it's a very simple idea and a very simple approach to solving the variability across patients. And then you can see that the enhancement is relatively similar across patients. So the dose variability gets taken care of by automated tube current modulation, and the contrast variability is also relatively straightforward. Now, the same principle does not only apply for CT angio, but it applies to everything else. So if you think about what the biphasic liver protocol is, essentially what it is you need a late arterial phase for a liver protocol because you want to see hypervascular liver lesions. So those are essentially acquired 16 seconds after the contrast arrives in the aorta, so it's a late arterial phase. And then you do a portal venous phase about 30 seconds after that. But again, the protocol is the same for everybody. We have the scan time is 6 seconds with a flow rate of 4 gives 120. Smaller patients get less. Larger patients get more. Very straightforward, and it's a very simple acquisition. And again, the reason is because the arterial enhancement corresponds actually to the enhancement of a hypervascular liver lesion. So this is why you want to have this constant as well. For the pancreas, it's exactly the same. Here we have just a longer delay because the pancreatic phase is about 25 seconds after the aorta enhances. And again, you combine the pancreatic phase with the venous phase. And again, all the protocols have usually the same scan time, same injection duration, and they have different volumes and flow rates for the injection protocols. Now, runoff protocols. So here's a slight variation, and the reason is because, as I mentioned earlier, this patient with peripheral artery disease, they can the blood flow can be very slow. So it can be as slow as only 30 millimeters per second. So it may take up to 24 seconds to get from the aorta to the popliteal artery. So if you want to include this into an injection protocol, so you have to make your scan time very slow and your injection long. So you have a 40 seconds of scan time because we don't want to outrun the bolus, and we have a 35 seconds of injection duration. The reason why we can make it short is because we're going to catch up with the bolus while we travel down the aorta. Now, here is the injection protocol. So if we inject at, let's say, at 75, if you have a single phase injection protocol, one of the disadvantages that's going to happen if we just have a injection of, let's say, 4 cc's per second for 35 seconds is that also what we learned for a long time is that if you have a long injection duration and you look at the enhancement of the lower extremity arterial tree, you will notice that the enhancement is usually very bright in the popliteal artery, and it's worse near the ankle, and it's also very bad near the aorta. And would this surprise you that you typically get an arterial enhancement that is highest in the popliteal artery and then drops at the legs? Well, now it shouldn't surprise you at all, because it's the same standard effect that we always see when you have a long injection. It cumulatively increases over time. It will be just maximum when the scan is almost over, and then it drops again. So does anybody have a suggestion of what we could do to make this enhancement better in the lower extremity arteries. Particularly, what could we do to make the aorta a bit brighter? Because the aorta we still want to see. One of the potential solutions is that you could just increase the initial iodine administration. So this is one of the rare situations where we still use a biphasic injection. You will start your injection faster for the first 5 seconds or so, because this will bump up your enhancement of the aorta. And another solution would be to just wait 8 seconds or even longer. The disadvantage being that you have a totally even a longer injection. So again, this is one of the methods how you can make your injection, your aortic enhancement better. So this is why our runoff protocol has not only a 40-second scan time, but 35-second injection duration. It also still has a biphasic injection, so the average person would get a 25 cc's at a higher flow rate, and then continued at a lower flow rate. And this is just to bump up the initial enhancement of the aorta. Pretty much straightforward. Finally, the CT venograms. Again, the principle is the same. Again, you give more contrast to larger patients and less contrast to smaller patients. The one important trick for CT venogram is that it works very well if you give just a lot of contrast. Because here, it doesn't matter, in fact, how fast you inject, because the venous enhancement depends on, you need to recirculate throughout the body until it really enhances the veins. So the trick for that is just to give lots of contrast. So this is, in fact, the protocol with the maximum amount of contrast that we have, and that's our venogram protocol up to 2 cc's per kilogram. And we do a first scan at 110 seconds, and we park the scanner here for 70 seconds, and then we scan the legs for the rest. And usually this gives very nice image quality. If you use it or combine it with 80 kV, it in fact looks much better than with 120 kV. And then if you do that, you can in fact see these little filling defects here in the vein. So this is the artery. We're not interested in the artery. We're interested in the veins, and you see these little linear filling defects, which are chronic recanalized thrombus. That's exactly what you want to see in a CT venogram. So in summary, I hope I was able to explain the early contrast dynamics, or the relationship between intravenously injected contrast and arterial enhancement within the first minute. And it hasn't changed over the last few years, and it will probably not change in the next few millions of years either, unless I would say our political leadership will wipe us off this planet anyway. So you could really summarize contrast administration, or the principles of enhancement, by 4 basic principle rules. The first is enhancement is proportional to the injection rate. It also increases enhancement if you inject longer, but more cumulatively. You do need to adjust for patient size, and you also do need to adjust for a diseased vascular territory. And with this, you can build very simple and reliable injection protocols, and those are exactly the protocols that you are using every day here. And with this, I again thank you for your attention.